Talk about today ultrasound in gynecology. In the overview, you have to for ultrasound is used for uterine pathology, ovarian pathology, tubal pathology, and ectopic pregnancy detections. Okay, first is uterine pathology. For uterine pathology is the most commonly we have to diagnose the leiomyoma, that is fibroid of uterus. It has a various type of as per figure classification you have to divide. It can be intramural, subserosal, a submucosal component. Okay, how it is look like in ultrasound is fibroid. It is a focal, sharply marginated. This you can see here the margin, focal and sharply marginated. Okay, myometrial masses. It is hypoechoic. Somehow it is some point it is isoechoic or echogenic relative to the myometrium. You can see it's comparably hypoechoic content is there. Somewhere it is almost isoechoic or echogenic also in some points. Surrounding myometrium compress forming surrounding myometrium is compressed and it's form a pseudo capsules. You can see here so the pseudo capsules. Okay, the compressed lymphatics and vessels, thin hypoechoic cream around intramural leiomyoma. Okay, then this is a ultrasound of submucosal leiomyoma. You can see this is the submucosal leiomyoma. It is originated from the mucosal bed. Endometrium is originated from the intramural component. Has it is bulging into the endometrial cavity. It is a saline infusions saline infusion sonography. After instillating saline into the endometrium cavity, it can easily delineate your submucosal myoma. Okay, adenomyosis and other things you can see in ultrasound is adenomyosis. The feature of adenomyosis in ultrasound, you can see there is a diffusely globular uterus with smooth external uterine contour and asymmetric globularity. Myometrial cystic area echogenic foci will be there. Pseudo thickening of the endometrium, diffuse increased internal vascularity, striated edge shadow or Venetian blind appearance without discrete mass, focal ill-defined mass. Feature that help to differentiate from leiomyoma. What are the features you can differentiate? In leiomyoma, compared to leiomyoma, it is a smooth external contour of uterus. Leiomyoma, it is the irregular surface. Minimal mass effect on serosa because adenomyosis is not a ill-defined mass, so it is a minimal mass effect on serosa and endometrium relative to the size of the lesions. There is a no calcifications. You cannot get any calcifications. Ill-defined margins. Central here you can get a central versus peripheral vascularity. Okay, you can see here the adenomyosis. This is the endomyometrial junctions thicken. This is the Venetian blind appearance. This is some myometrial cyst. This is myometrial cyst. This is some myometrial translation, myometrial stripe lesions. I don't know, myoma versus leiomyoma. There is translational vascularity is there. Then congenital uterine malformation also can be detected in the ultrasound. First, it is a normal or arcuate uterus. You have to see the depth from the fundus to the indentations. If depth is less than 1 centimeter and the angle, okay, the angle is more than 90 degree. Here you can see the angle is more than 90 degree. Then it is called arcuate or normal uterus. Then in the septate uterus, the depth from the fundus to the indentations is more than 1.5 centimeter. Septate uterus angle is less than 90 degree. Okay. Then in bicarbonate uterus, the depth of indentations is more than 1 centimeters. Okay. You can see here the didelphic uterus, note complete separation of uterine cavity. Okay. Here didelphus uterus you can see very nicely. Didelphus uterus, note complete separations of uterine cavity in the didelphus. This is one uterine cavity. This is another. Okay, in transverse plane you can see two total separate uterine cavity in didelphus, but left hand sagittal note that only one plane the uterus can appear normals. This is a bicornate uterus, the 2D image. This one horn, this is another horn. Note this concave surface. This is the concave surface, frontal country indicating bicornate uterus. And this both horns communicating. Okay, this is the right horn. This is the left horn. This is the right ovary. This is left ovary. This is your cervix. You can see very nicely. Okay. Then in the septate uterus, how to in the septate uterus there is a two separate but the closed endometrial cavities septum. Here the septum is up to the internal os. Okay, the septum is up to the internal os. This is here, internal os is here. Okay, there is no fundal indentation. The fundal contour is maintained. There is no fundal indentation as such, but there is a septum inside the originate from the myometer into the endometrial cavity. Is divided the uterus into two separate part, but close. But this endometrial cavity is very close to each other. Okay. Here the arcate uterus, there is a small indentations is there. Small indentations is there. Okay, small indentations will there, and mymetal indentation, outer fundal is convex. Okay, this is the indentations. Okay, this is the indentation you can get, but outer is somehow convex. Okay, outer fundal serosa is convex. Then 3D ultrasound of bicarbonate and septate uterus fundal indentation using bicarbonate uterus. How will differentiate the fundal indentations, because both there is a, I told there is no fundal indentations in the bicarbonate uterus. In the septate uterus there is somehow fundal indentations is there. Here is the septum, bicarbonate uterus and the septate uterus. Now you have to differentiate the bicarbonate and septate. In the septate uterus, I told there is a septum, there is a no fundal indentations, and in bicarbonate also you have to draw a line contact to the tip of each endometrial leaves. You have to draw a line. This is the endometrial leaves. This is the endometrial cavity. This is another endometrial bicarbonate uterus, but double hand, right and left. You have to draw a line on the tip of the each endometrial leaves. Okay, you will draw a lines. Okay, then measure the distance between the lines and the deepest frontal indentation. Just the deepest frontal indentations. This is the deepest frontal, the distance have to measure. The measurement is 5 less than 5 mm. If it is a less distance, then it is a bicarbonate uterus. If it is a more than 5 mm depth, septate uterus. Okay, very important, the distance. Okay, frontal indentations distance, starting of the frontal indentations more than 5 mm. Then gestational trophoblastic neoplasia, you can see the complete hydatid moles. So this complete cavity is full of all these hydatid form moles, and that is grape-like vesicles. And this is a partial hydatid mole. So you can see some part, the fetal part is formed because it is partial. So fetal part somehow it is formed, but sometimes the rest of this is some hydatid form tissues like grape-like vesicles in the placental sites. This is a coexisting mole. Already this is a totally coexisting mole and live fetus. This is a live fetus and the coexisting mole is there also. This is an invasive mole because you can see the how the molar pregnancy tissue, that trophoblastic invasion is completely into the myometrium. So invasive mole. Choriocarcinoma, you can know choriocarcinoma, it is a metastatic tumors that is can easily, it is metastatic to lungs. Okay, very important topics. And the placental site trophoblastic tumors, this is the placental implantation site, the invasions is there. Okay, the next is you can see in the ultrasounds how it is look like the molar pregnancy, partial, complete mole. There is a cluster of grapes appearance, endometrial cavity distended with ecogenic cystic metal. How you see the small cystic structures there in the endometrial cavity, the small cystic and ecogenic cystic material with peripheral vascularity. You can see the periphery has a vascularity. You can see the how the vascularity is look like. Okay, there is some cystic spaces are there. This is already some fetal part is there. Then this is the city, this is the partial mode. Okay, with peripheral vascularity. Then this partial hydatid mole in amniotic cavity, gestational sacs either empty or containing amorphous inappropriately small fetal echo, which may be surrounded by a relatively thick cream of placental echo with the intermingling cystic spaces. You can see these intermingling cystic spaces. This there is some amorphous material, fetal body parts is there. Okay, this is the here. Then ABM, how to differentiate serpiginous cystic spaces or a tangular tubular anechoic blood vessels. Tangle of tubular, you can see the tangle of tubular anechoic blood vessel is there. So this high velocity, and if you do high velocity, there will be a high velocity low resistance waveform, and in feeding artery, and pulsatile high velocity flow in the draining vein. Okay, very high velocity low resistance, high velocity low resistant waveform in the feeding artery, there will be high velocity low resistance, and the facility high velocity flow in the draining vein also, that is the signs of AVM. Okay. Then in the pseudo aneurysm, there is a anechoic cystic structures. You can see the cystic structures taking the vascularity, pseudo aneurysm. On Doppler, swirling of blood flow with yin yang patterns, that is pseudo aneurysm. To and fro pattern with flow heading toward the PSA during systoles and AOA during diastoles. Okay. Then how it is look like intrauterine contraceptive device, you can diagnose in ultrasonography if it is a missing cavity or something. If you're missing cavity thread, you can go for a misplaced or missing threads. So that cases can go for this ultrasound to get the proper locations of the cavity. Then as for that, your plan is manage whether you go, how to manage, what are the precautions to be taken before the preoperatively plan. The bright echosonic structures with dense posterior shadowing within the endometrial capture. You can see the bright echosonic structures. This is a bright echosonic structure with the posterior shadow is there. Okay. This is the total is the cavity. Okay. This is the, it's somehow it is penetrated into the myometrium. Okay. Remember the bright echosonic structures with dense posterior shadowing is typical features of a cavity or LNG or any IUCD. Okay, then ovarian pathology. Already I told you uterine pathology. Now we are going to ovarian, then tubes. Okay, then the ovarian pathology first you have to remember the iota classifications. There is a B rules and M rule. First one is B1. B1 is unilocular. You can see the unilocular simple cyst is there. B2, the presence of solid component, but that solid component with largest diameter is less than 7 mm. This is the solid component, but the solid component size is less than 7 mm. Very, very important. This is a template cystic structure. Only the small solid component is there with largest diameter is less than 7 mm. In B3, you can see the presence of acoustic shadow is there. Presence of acoustic shadow. This is B3. Then the B4 is a smooth multilocular tumor with largest diameter is less than 100 mm. Okay, this is the smooth tumors. This is a multiloculated. This is the locule is there. Multiloculated smooth multilocular tumors, and the largest diameter is less than 100 mm. Okay, this is B4. In the B5, you have to do the color scoring. There is no blood flow into the lesion of the tumors. No color score is 1. Then M1, malignant features. There will be irregular solid tumors. You can see how the irregularity is there. The irregular solid tumors is there. Okay. Then M2 is presence of ascites. Typically, you can see the how the ascites is there. M2 is the ascites. Irregular solid tumor. M1. M2 is the ascites. Then M3 at least M3 is at least 4 papillary projections is there. You can get the 4 papillary projections. Have the 3 mm. If when you call as a solid papillary projections, if it is a the vertical height is 3 mm, more than 3 mm, then it is called papillary projections. You can see the papillary projections. This total at least 4 papillary projections should be there to call as a malignant features. Okay, M3. Then in M4, irregular multilocular tumors with largest diameter is 100 mm. You can see the how irregularity is there. It is a multilocule. This locule, this is another locule, this is another locules. Multilocular with the largest cell diameter is more than 100 mm. Then M5 is the very strong flow. That is color flow is 3. Very, very important. This you can see the entire tumor is getting the color scoring. All is having high scoring. So M5 is the color score for strong, very strong blood flow. Okay. You can see the color scoring is given when no blood flow is detected in the cyst, that is color score 1. There is at least into the cyst there is no blood flow. Surrounding structures has been, because the referring supplying will be there, that is blood vessels. Okay, but into the lesion there is no blood flow, the color score 1. If it is a color score 2, you will given only when the minimal flow into the cavity. This is minimal flow, so you give it 2. Color score 3 is given when moderate flow is there. Moderate flow is there here and moderate flow is there. Then color score 4 given when the Adnexal lesion is highly vascular. Highly vascular. You can see the totally lesion is taking all this vascularity with marked blood flow diagram. Okay, this is orals. Then after that you can see the benign features. If it is a benign features, only B features apply. If any B it's benign, if any M it's malignant. If you are getting there is no features up conclusive in, if you have tried inconclusive, or you can get both B and M simultaneously, then it is also an inconclusive tutor. Can be used to classify 75% Adnexal mass. M and B rules. Sensitivity is 90%, then specificity is 84%. Very, very good. M and B rules is very nicely written. A simple ovarian cyst, how it is look like in it. Usually we are going for an annual follow-up for cyst larger than 1 centimeter, though some practice may choose to raise the threshold to 3 centimeter, recommended in postmenopausal women. In premenopausal women, it's recommended that cyst between 5 to 7 centimeter in largest diameter be followed yearly by ultrasound. You have to go for a yearly ultrasound. Yearly, you have to go for ultrasound USG. Okay, for follow-up scan. Only simple appearance is nothing to do, only unless it is a more than 8 centimeters, you good some operations or something to do after tumor marker doing. If there is some suspicious malignancy, you should go for a surgery. Simple appearance is color Doppler image. Simple appearance is can demonstrate characteristic finding, and okay, contain smooth thin wall. Very very important. You can see the how thin wall it is. How thin wall, smooth wall, regular surface is there, no irregularity in between, no internal vascularity, no internal vascularity. How nicely they have written here. And posterior acoustic shadow you can get in here also, posterior acoustic shadow. Then hemorrhages is very very important differential diagnosis. So many patients will come all this hemorrhages don't have complaint of pain, sudden pain abdomen. Hemorrhagic variances, you can see how the fibrin threads is visualized in ultrasound, like it is a fish net appearance or net like appearance. How nicely they have, you can see here in the ultrasound pictures, fish net. Okay, fish net, this is fish net appearance. Okay, the fish net or reticular less like patterns of internal echoes due to fibrin strands. Fibrin strand typically appear as thin linear curvilinear echo that don't extend across the span of the cyst but appear discontinuous. True internal septation. Always remember the true internal septation has a usually it is goes from one wall to another wall. Okay, that is true internal septations. But fibrin strand, in between you can get a interpretation, not at continuous septations at continuous strand. It is continuous. Okay, one wall to across the cyst. Hemorrhagic cyst from another patient, it has a solid appearing area with a concave margin. Then it is, if a solid appearing with concave margin due to reticular retract, it is a retracted clot. After hemorrhage there is a retracted clot, so it become a concave surface. It look like a solid component, but it is not like that. Okay, and the colored image also not demonstrate any flow into the clot. Okay, the PCOS in string of false appearance more than 12 follicles, peripheral place with or without increase in ovarian volume. You can see the string of balls like peripheral follicle with increased stromal echogenicity in the center. In adnexal torsion, presence of unilaterally enlarged ovary, usually larger than 4 centimeter, with or without associated mass. String of false signs, peripheral displacement of ovarian follicles secondary to the stromal edema or venous congestions. Follicular ring, a perifollicular hypoechoic ring 1 to 2 mm thickness seen surrounding the small 3 to 7 mm peripheral anterior follicle of the torsion ovary. Doppler finding vary with the degree of torsion, the time course, and the vascular compromise. Wheel sign will be there in the adnexal ovarian torsions or adnexal mass torsion. You can see the ovarian torsons without associated mass viable ovary is there. The point A is a point, you can see here the transabdominal scan demonstrates the enlarged, the ovary is enlarged, totally it is enlarged ovary containing multiple peripherally arranged follicles. You can see the multiple peripherally arranged follicles is there. The ovary is located posterior to the uterus. You can see the ovary is located posterior to the, this is the uterus, behind the uterus the ovary is located. In B point, you can see the transvaginal scan of the ovary is enlarged. You can see the how the ovary is enlarged. This is the ovary, how the ovary is enlarged. Okay, with heterogeneous ecotexture, peripheral located follicle with string of walls. This is, you can see the peripheral located compressed follicles. Then C point, you can see the congestions vascular pedicles. C is congested vascular pedicles is there. Noted lateral to the ovary. This is the ovary totals, and this is the congested vascular pedicles. This is the congested vascular pedicles. There is a small amount of adjacent free fluid also is there. This is the small amount of adjacent free fluid is there. And arterial flow to the ovary is preserved. Arterial flow is there. You can see the arterial flow is there. With a color spectral duplex Doppler sonography, whole appearance of vascular pedicle, and the this is a whole appearance of vascular pedicle and the Doppler sonography. Then in endometriosis, sonogram spectral endometriosis, the classical appearance of chocolate cyst with homogeneous low level echo, the ground glass appearance, posterior acoustic enhancement, confirm a cystic lesion, no vascularity is demonstrated. Within the lesion, there is no vascularity, but here the peripheral vascularity is there. more complex heterogeneous appearance in other patients as a result of acute hemorrhage, because here hemorrhage is there, so it is looking like a complex cyst. Chronic endometrioma mimic a solid adnexal mass. Avascular mural nodules suggested arrow. There is a avascular mural nodule is there in the E points, representing the adherent clots. Complex cyst possible mural nodules suggest the appearance of stimulated ovarian neoplasm. Echogenic foci along the wall with cometial signs. Echogenic foci help suggest diagnosis endometrioma. Then complex endometrium mimicking ovarian neoplasm, 10 centimeter ovarian cystic mass with septations. You can see the septations. Black arrow is the septations and white arrow is the echogenic mural lobulated mural nodule. No flow was demonstrated in the nodules. There is in the nodule there is no flow. Double integration is possible to adherent blood clot. If it is no flow, that is this would be a adherent blood clot is there. T1 weighted magnetic resonance imaging demonstrated the lesions hyperintense suggesting hemorrhagic content. This is the hemorrhagic content is there. Note adherent similar appearing lesion. Decrease in signal intensity with both lesion. Setting if a dependent clot is visible in the larger midline. Post contrast demonstrated enhancing solid component. Endometrium were confirmed at surgery. Mature cystic teratoma, ovarian dormant. This is dormant, diffusely hypoechoic. There is adjacent hypoechoic ovarian parenchyma. The dormant with hypoechoic lines, dots. This is the hypoechoic lines. These are the hypoechoic lines. Some dots are there. This also has hypoechoic peripheral component. The uncommon, the presence of hair follicles within hair follicle within the lesions. It is a dots. Uncommon pathological appearance of dormant containing several spherical structures, some of which are non-dependent, thought to replace floating fat vessels. These are the floating fat cells, fat balls, spherical structure contain fat which allow them to float. Dysarminoma is a bearing texture, usually solid and well encapsulated. This is well encapsulated solid with a prominent flow signal with fibromuscular septate. This is the fibromuscular septate with prominent vascularity. This is a granulosal cell tumor, appears very widely, may appear anywhere from a solid mass to multilocated solid cystic mass, purely cystic lesion bearing degree hemorrhage and fibrous, less likely to have intracystic papillary projection than epithelial tumor. This is a complete vascularity. Tubal pathology. Here you can see the endometritis. Demonstrated endometrial cavity are containing complex predominant hypoechoic fluid in a febrile patient with purulent vaginal distress. This is the collections. Pyosalpinx distended thick walled fallopian tube containing complex fluid comparable with pyosalpinx. Pitfall: acute appendicitis debris filled with tubular structures also make a differential diagnosis. In the right Adnexal is initially thought of to represent a pyosalpinx. However, no endosalpingeal fold to be identified in this blind ending structures. Complexity so confirm acute appendicitis because there is no fold, endosalpinx fold, so in CT it is like appendicitis. Then tubovarian abscess, multiloculated mass containing complex fluid, no normal ovaries identified. Hydrosalpinx, anechoic fluid filled vascular incomplete septations. Incomplete septations is there. Incomplete septations. Sonography split dilated fallopian tube appear anechoic fluid filled avascular tubular structures. Endosalpingeal folds appear to be bead unstring appearance. Incomplete septations arrow formed by the tube folding of its cells. Gus tube folding the hydrosalpinx tube fold upon its pitfall. Mucinous adenoma appear tubular contraction with incomplete septations mimic distended fallopian tube. In ectopic pregnancy, you can see the pseudo gestational sac. This is sac. Okay. Ring of fire signs you can see here. This is the pseudo gestational sac. This is the ectopic pregnancy presenting as a non-specific adnexal mass. Rupture ectopic, you can see the hemoperitoneums. This is organized clot. Corpus luteal versus ectopic. Corpus luteum is thick, crenated, moderately echogenic rim, irregular cystic center with few internal echo. This is the crenated with few irregular cystic structure, crenated margins, moderately echogenic rim. Oh. This is the corpus luteum. Angle between ovary and the tubal ectopic is acute in ectopic pregnancy. Angle between the ovary and corpus luteum is obtuse. You see the crescent ovary tissue surrounding part of corpus luteum. This is degenerative myoma versus ectopic pregnancy. Thick echogenic cream with central cystic component. Thick echogenic cream with cystic component inside the bridging vessels arising from the uterus. These are the bridging vessels. These are the bridging vessels. Interstitial and versus angular pregnancy, eccentrically located away from the endometrial cavity. This is the eccentrically located away from the endometrial cavity. This is the endometrial cavity is fine. This is the eccentrically located mass away from the cavity. Thin surrounding myometrium. There is a thin surrounding myometrium. There is a angular pregnancy. There is no intervening myometrium. Angular pregnancy. It is angular pregnancy. No intervening myometrium between the gestational sac, G-sac, and the endometrium. Cervical pregnancy was inevitable aberration. The G-sac in the cervical tissue adjusted to the echogenic endocervical canal. This G-sac will be seen in the endocervical canal. Centrally in the abortion, centrally located in the endocervical canal. Centrally located. Centrally located. There is no G-sac. This is the oxygen scar pregnancy. There is a thin myometrium mass anterior to the isthmus. This is the isthmus seal. This is the G-sac. Empty endometrial cavity, empty endocervical canal.